Hello everyone, welcome to our knee osteoarthritis webinar. My name is Josephine and I'm Head of Marketing and Sales, and we're delighted to introduce Mr. Tofunmi Oni, who is one of our Consultant Orthopaedic Surgeons here at the Horder Centre. He completed specialist training in Kent, Surrey and Sussex before advancing his expertise in hip and knee joint surgery through a fellowship in Sydney, Australia, where he gained extensive experience in complex and computer-assisted surgical techniques. We'll take a closer look at understanding knee osteoarthritis, how it affects you, and the treatment options available, including the latest in robotic surgery. Before I hand over to Mr. Oni, please can I remind you that this is a live recorded event. Your camera and microphones are turned off. And if you haven't done so already, you can change your name to anonymous or pseudonym by following the instructions we sent you earlier today. Please note, we can't respond to raised hands during the session. If you have questions, type them in the Q&A section. You'll see a little icon at the top of the page and we'll address them at the end. We'll also try to cover the questions that you submitted during your application. Once again, thank you for joining us and please welcome Mr. Oni. Actually, I like to call him Tofi. Thank you very much. All right then.
Perfect. Hello, everyone. Welcome along today to this webinar. I'm Tofunmi Oni. Most people call me Tofi. And I hope everyone can hear me and see me as a little box in the corner. But today we're going to talk about knee osteoarthritis. Broadly speaking, what it is, and a little bit about how it happens. And then we'll move into management options, and then obviously we'll touch on something that's really close to my heart, which is robotic surgery towards the end. So let's crack on. So what is it? So what's osteoarthritis? So ultimately, in the simplest term, it's essentially gradual deterioration of the joint. That says deterioration of the articular cartilage. And what that means is the cartilage that essentially is stuck onto the end of bone that helps to prop both surfaces apart. And if you look at the x-rays on the left-hand side where it says normal joint space, what x-rays are very good at doing is inferring the amount of cartilage that's left. So that's a normal picture on the left where you can see space, and on the right it is rather severe osteoarthritis, and I'm sure you can appreciate all of that space is lost. Typically there are some classical changes that go along with that loss of cartilage. The bone changes underneath it because it is taking a lot more weight. It's no longer cushioned by the cartilage. The lining of the tissue, that's the synovial membrane, becomes very inflamed, and that inflammation actually leads to a progression of the deterioration of the cartilage through quite a complex sort of structure, but a lot of molecules are released in that inflammatory process, which means that once it starts, it tends to snowball into a situation which gets worse and worse fairly quickly. But all of that results in really what my patients present with, which is joint pain, often joint stiffness, a general sort of functional impairment, difficulty with activities of daily living, difficulty with sleep. All those sorts of things are what people present with, and a little bit about the epidemiology, which is it's extremely common. It's not just something that is rare, clearly, but it happens very, very, very often in lots of in this population in this country, and it's the leading cause of disability amongst adults. And so you have a situation where the older we get, the more our joints wear, but also there are other ways of getting there. There are what's called inflammatory types of arthritis, where the body is attacking its multiple joints, or you can have arthritis that's caused from an injury from, you know, for instance, when one is younger. So there are multiple ways of getting to the same place, but all in all, the disease process is a loss, ends up being a loss of that that cartilage, as you can see. So just a little bit about how surgeons or GPs or doctors in general tend to diagnose it. I like to think of it as an algorithm, and it's quite a simple algorithm, really, because generally the older we all are, the more that our joints tend to wear. And so someone who is a little older, again, that makes it more likely that arthritis is the reason they present with joint pain. The arthritis always presents with a level of pain, often with instability, and almost always with a level of stiffness, even if it's not noticed by the individual. And further clues that I start to look at is where exactly the pain is, because most people have most of the forces going through the inside of the knee, and so the inside of the knee is the most common place where people tend to get pain. Now, there are a lot more sort of nuanced parts of the algorithm, but I'd say that's a very basic starter for 10 as to when things start lighting up in my mind as to, you know, pointing towards osteoarthritis rather than anything else. So we've now got to a situation where we've diagnosed osteoarthritis by talking to the patient, following their algorithm, seeing the x-rays. And the key thing to mention here is osteoarthritis is a spectrum. It is not something that you have and therefore you have to do something about. There are lots of people walking around with osteoarthritis that aren't in any discomfort, and there are some people that are completely crippled by it. So it's worth tapping in to just how much it's affecting that individual's quality of life, which is what I aim to do every time I see a patient. But when it comes down to the treatment, the first thing is conservative management. And so we know that just simple lifestyle modifications can make a huge difference. So weight loss, as difficult as that is, does make a huge difference. Doing low impact exercise rather than running. So by low impact, I mean things like swimming, cycling, even rowing sometimes, can make a difference. And that's goes hand in hand with physiotherapy, because all of that is aiming to strengthen the muscles around the knee, so that the muscles essentially support the knee better, and also can help to reduce stiffness. And all of that is taken in conjunction with analgesia as well, can lead to a point where symptoms are managed without having to intervene anymore. If those start to fail, then we start looking at interventions, and the first thing I would consider is injections. Now, this is something that I don't consider in everyone, and truth be told, with severe osteoarthritis, things like steroid injections or visco supplementation, so that's hyaluronic acid, those type of injections have the ultimate aim of reducing inflammation in the joint. The visco supplementation does that, but also lubricates the joint to try and reduce symptoms. The reality of both of those two options is, as well as the PRP, which is platelet-rich plasma, is that they're mainly short-lived. So ultimately, that grinding away of the worn part of the knee still happens, and so the inflammation caused by that, it will always win, and that is why arthrosumid, which is the last injection option, is something that I've turned towards more than the remainder. It's a completely different novel injection, which is a polyacrylamide sort of hydrogel, and this works by integrating itself into the lining of the membrane around the joint, reducing inflammation like the others do, cushioning it like the others do. But the key thing is this doesn't get reabsorbed, and it has a structure that the body recognizes as its own. And so over time, you have incorporation of cells, the body's own cells, into that gel-like structure. And so in actual fact, this works better and better and better over time. And the trials at the moment are out to 5 years, showing that this is an option in the right type of arthritis. And this is a little bit more of arthrosamid, so it's long-lasting effects compared to the other injection options I mentioned. It's minimally invasive. It's just an injection, so no sort of diving in with surgery, and it's mainly for patients with sort of that middling moderate to just about severe osteoarthritis, who may not need a knee replacement yet, or indeed do not want a knee replacement. And that's a little stat at the bottom is just saying it's not new. So it's been made for the last 25 years, and it's over 12,000 injections across Europe. It's just new to the UK in the last couple of years. Following on from further treatment options, so often people ask about arthroscopy, so that's keyhole surgery, and what the last 10 to 15 years has taught us as surgeons is that there's actually quite limited indications for arthritis. So when you lose that cartilage that keeps the two surfaces apart, really keyhole surgery does nothing for that. What it does do well for is meniscal tears and the symptoms that come from meniscal tears. Now that image is designed to show what the menisci are. It's those two sort of C-shaped sort of structures that sit in the knee to help to spread the load. So it's a separate type of cartilage within the knee. And as the two surfaces come close together, usually it's a pincer effect on that meniscus, which can cause pain, but more frequently actually causes what we'd call mechanical symptoms. So that's clicking or the knee giving way, or indeed locking. And if those are the main symptoms that an individual has, then keyhole surgery does have an application, and people can be much better off from it. If it is just pain, then there's very limited indication for keyhole surgery. Again, building up from there, something that's fairly invasive, but generally reserved for younger patients, and that's an osteotomy. And an osteotomy means essentially breaking the bone and moving it across to realign the forces that go through the joint from a place that is worn to a place that isn't worn. And it's something that we very much consider for younger patients with very severe osteoarthritis. And indeed, the arthrosamid injection may well prove useful in this population. And then we come to the meat of it, so joint replacement surgery. Now, this is clearly the most common surgical treatment for severe osteoarthritis. It involves replacing the entire knee joint, or indeed part of the knee joint. Sometimes we do a partial knee replacement. It's highly effective over time, although I will add it's not a silver bullet. It's usually a journey to get to where a lot of people want to be, and that journey can look like discomfort, a lot of hard work over months, to the point where often people think they shouldn't have had it done, but usually pushing through that and rehabilitating yourself through that usually leads to a very good outcome, and most people get better and better all the way out to a year down the line. So looking at the longevity of knee replacements, in this country, the National Joint Registry has been collecting data on knee replacements for the last 20 years. And what we know is at 18 years, for sure, for certain, there's approximately 90% of knee replacements have not needed to be done again. That's if they are still needed, of course. But as you can see, those stats show it's an extremely successful operation. So getting into the meat of this talk for me, which is the conventional knee replacement versus robotic or computer assisted knee replacement, and to understand the difference, what I want to do is talk a little bit about what a conventional knee replacement is, what we've been doing for years, what I still do now, and the aim is to reshape the end of the thigh bone, the femur, into almost like a block shape, as you can see on that picture. Reshape the top of the tibia, which is the shin bone, into a flat structure, and then have both bones covered in metal with a plastic in between, as you can see on the left-hand side picture. The way that we do that is by attempting to align the joint as accurately as possible, and that's what the right-hand side picture is trying to see. You're trying to get all of the joint line. Oops, sorry, just one moment. Light went off. You're trying to get the entirety of the joint line and the entirety of the joint in a balanced way, and the way that we do that is with things called external jigs. This is a picture of what those jigs look like, and so sorry for anyone who's a bit squeamish, but on the right hand side is during the operation you use certain alignment tools, and you have a best guess alignment according to the patient's anatomy, and on the left hand side you can see what it often looks like from the side, depending on the type of alignment jig. So those are used to I suppose match up the patient's anatomy as you're looking at it, but as you can see, it's not necessarily an exact science. This is a video of what I consider to be a conventional knee replacement. It's a few minutes long, but I'll skip ahead. It doesn't have any sound, so I'll describe some parts as we go along, and I hope it's useful to have a look at. So that's what your knee looks like, and in this is going through replacing the kneecap, which often is done at the end of the procedure. A lot of my colleagues don't, but I tend to always replace the kneecap to avoid anything getting worn in the future. And this is the alignment I was talking about. So essentially a hole is made up the center of the thigh bone, and the alignment is found down the center, and those structures are pinned in place and used as a guide to essentially create that box-like shape that we saw in the previous image. So that's the saw, just making the end flat. Some more alignments and measurement structure implements are used, and then another instrument is used to finish things off, creating the sort of box structure, which looks like, after that comes out, which looks like that. And so that's the end of the thigh bone. That's ready, and then you match a similar thing on the other side. That is the external alignments that I talked about, and that's open to interpretation and open to the experience of the surgeon. And that jig's pinned in place, and the top half of the shin bone is cut flat, as I spoke about. If I just skip ahead, and then you create something that's a mold that fits on both sides, and that is what a knee replacement looks like at the end. So I'm not going to labor this video because there's another sort of minute or two, but I think that just gives a bit of a flavor as to how a conventional knee replacement works. And now to robotic knees. So the first thing to show is that, or the first thing to say, I suppose, is the information that that's used is very specific, and it's specific to the patient, and it's extremely accurate. And so the machine on the left-hand side is the robot. This particular one's called the Rosa. That's what we have here at the Horder Centre. And what the first thing we do after opening up the knee is to map that patient's specific anatomy, and all that information is relayed to the computer in the robot, and the specific nature of that patient's knee, the gaps of that patient's knee, the alignments of that patient's knee is mapped out, and we can optimize the specific type of alignments that we choose for that specific patient. So it's no longer an external alignment that's open to interpretation. It's giving the computer and the robot the information for that specific knee, and we work together to create the highest the balance for that specific patient. So this is a sort of 90-second video. This does have sound, and it just gives a little bit of an introduction to robotics and how that differs from a conventional knee.
Rosa Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. Rosa Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. Rosa Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjust accordingly. Rosa Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy. To learn more about total knee replacement with Rosa Knee, call toll-free.
So I think the key message with that is information, is data, is accuracy, and all of that is filtered through into the actual robots. And after we plan exactly what we want to do for that specific knee, then the robot essentially helps us to execute it. So it's not just the case of planning what needs to be done, but the robotic arm, as you saw in that video, comes in and actually guides our cuts to make sure that we cut exactly where we plan to. So this is the ultimate, I suppose, last couple of slides. This is the ultimate question: why robotics? And I think this is something that that is often talked about, even amongst my peers. For me, it's the precision. The precision. There's no doubting that the robotics gives us high precision in what we want to achieve, and so there's no way of coming outside of exactly what you want to achieve. So if I wanted to cut A, then the robot will help me cut exactly where I'd like to. Whereas a non-robotic system may be open to interpretation in that particular situation. Obviously, it creates that 3D model that you saw of that specific knee, as it said, and here it says the personalized surgical planning, which utilizes all that data to then deliver the correct balance for that patient's knee. So what is the evidence on this? So the often people talk about how the jury's still out, and there's still more and more evidence that's been developed. Most global evidence is actually not in this country because we haven't quite embraced this technology. Places like the States and Australia have used it for the last 15 to 20 years. And this study, which looks at computer-assisted knee replacements, robotic knee replacements rather than conventional knee replacements, generally is said that it leads to better functional outcomes, so that patients tend to have a higher level of activity afterwards, and also talks about specifically better revision rates, so lower chances of the knee needing to be done again. However, I did say that it is a very good operation, and 18 years, over 90% of them are going. And so for me, it's more about the function. It's more about getting patients to as high a level as possible, as normal a knee, in inverted commas, as possible. And I think that the key message with robotics, which I think often people miss, is it's not a surgeon, so say me versus another surgeon, so a robotic surgeon versus another robotic surgeon. It's very much me using the robot versus me not using the robot. And people, I think, need to look at it as in you can increase the level of accuracy and the level of functional outcome in your own hands as a surgeon, as opposed to comparing yourself to others. There's also a lot of evidence around reduced post-operative pain and faster recovery, and that's because generally you know exactly where you want to put the implants, and generally the way that we do things means there's less soft tissue damage, which can lead to decreased post-operative pain. So lastly, there you are. Robots not taking over the world, just your knees. So I'm going to leave it there. I know that there were quite a few questions that popped up already, and I wanted to keep that as short as I possibly could while still answering some of those. But this part of the webinar is what I'd like to expand on. So I want to directly answer any questions or queries or anything that people might want to talk about.
Okay, hello. Thank you for that presentation, Mr. Oni. It was really informative. We do have a few questions. I've actually popped a couple of them into the chat myself because I've taken them from the questions that people asked when they actually filled in their application. So one of them said, how long does a knee replacement last? Is it for lifetime, or will it need to be replaced at some point?
Yeah, so according to the National Joint Registry data we have at the moment, most people who have a knee replacement have one knee replacement. And that's because the longevity of them is very good. And that goes back to that statistic about 18 years, 90% of them are still going. And so it's very much, the odds are very much in people's favor that it's just one. And often it will last 20 or 30 years with the new materials that we have these days.
I didn't realise it was as long as that. Also, we have another one here who says, I think it's really asking about the recovery time, what the expectation is going back to exercising. I know you did mention sort of hill walking, running, cycling. Can you answer that? Yeah,
sure. I mean, the aim of a knee replacement, I think, is to remove pain, and by proxy increase function. Often people talk about the fact that they always know that they have a knee replacement, so it doesn't feel 100% normal. And this is why going back to what I was saying about robotics, that normal feeling of a knee is what we're trying to sort of push to people having. But in terms of the recovery, from the beginning, often people are in hospital for a night or two. As soon as they're safe and they're pain controlled, then you're allowed to go home. What we get out of a knee replacement is directly linear to what you put in. In other words, it's weeks of hard work. Usually by the 6-week mark, people have a good range of movement, but are still struggling with sleep. Still not really quite there. At the 3-month mark is when people really start to kick in terms of returning back to a high level of activity that they want to. And then improvement happen all the way out to a year, like I said. But everyone's individual. You have to follow your own course of recovery. But equally, that the harder one works with their rehabilitation, then the faster the recovery tends to be.
Okay, thank you. We have another one here. It's just been posted. I have hypermobility in my legs. Does this affect the success rate?
Not really, to be honest with you, because generally a knee replacement is balanced off your own anatomy. And so when we put those components in, whether you're extremely tight or extremely loose, we balance it to that specific soft tissue envelope. And so generally, often, a lot of my patients with hypermobility often find that they have much more stability after a knee replacement than they had prior to knee replacement.
Okay. Right, we have a new one here. Oh, hang on. Covered in emojis. Hold on. What are the risks of failure of a knee replacement?
So by risks of failure, I'm going to take that to mean complication rate, rather than absolute, or maybe the person means the risk of it not working. And I'll try and answer both of those two things. So the first thing to say is that nothing's perfect, and that there are risks around a knee replacement, most of which are 1% to 2%, and that's things like excessive bleeding or infection, damaging nerves, arteries, and veins around the knee, the bone breaking around it, or it coming loose. So those things can happen; they just don't happen very often. But in terms of failure, where individuals have a knee replacement but they're no better off, and that is something that we do see, thankfully, rarely. But that is a risk, and I would say that, you know, something that's the lower end of the 5%, those sorts of things, and it very much depends on why you've had the knee replacements and specifically what your knee looks like. And so I don't think it's always a blanket answer for everyone saying this is everyone's risk. It's very much individual. There's some patients of mine that according to their anatomy and the way that they've worn, that we will have a conversation, and I will say your risk of this not working for you is higher than the average person, and so there's some people that are better than the average person. So it is an individual thing.
Okay, thank you. Now we've got one here. It's quite a long question, actually. Is the criteria for acceptance for knee replacement surgery traditional or robotic? Contraindications to knee replacement surgery, is there an upper BMI limit for a successful surgical outcome? Also asked what the NHS waiting list times are once accepted and listed for surgery. And as a private patient, waiting list times once accepted, so they want to know what the private patient waiting lists are on average, and I think actually looking from after diagnosis, how to get through the patient pathway. I think what they're looking at is actually from coming in for their first outpatient appointment, how long would it take to have surgery, I guess.
Okay. So I'm going to try and unpick all of
Sorry, there were a lot there.
There's a lot going on there. So the first thing I think you mentioned was about contraindications for surgery, or whether there's an upper BMI limit. And really the only, I would say, the only thing that I would suggest all patients who have a knee replacement must have is pain. That is that is primarily what you're trying to cure. So that's the first part of that. Going back to BMI, is there an upper limit of BMI? In theory, no. In reality, yes. And the reason why I say that is, in theory, what we know is that anyone can have a knee replacement. You can put a knee replacement regardless of your BMI. But the reality is, there's a magical 40 BMI, which is the BMI points of 40, and that's because a lot of evidence has come to light in the last few years, that states that if your BMI is over 40, then many of your risks is 10 times over the average. And so what we like to do is try and take that risk away from patients by asking them to reduce their weight if they can, and then the likelihood of them having successful operation increases drastically. Also, I know that in the Horder Centre there is an upper limit, and that's to do with the likelihood of needing a high dependency care. Again, it's higher if your BMI is over 45, and that's something that the Horder Centre doesn't have. And therefore, for the safety of individuals, it's not something that we look at in this setting here.
Right. Okay. I just saw something. Right. I'm going to read this one out. Actually, just bear with me. It is.
Sorry,
right.
You, Josephine.
Yes.
There was a second half of the question I didn't really answer, wasn't there? It's the waiting times.
Sorry. Waiting times.
Yes, waiting times. So it's a multi-part question. So waiting times at the moment. So firstly, I think the second part of the question was if you were a fee paying private patient, and that really is there's very little waiting time, and so it very much depends on how quickly we can get you into pre-assessment, which looks like a turnaround of something like 4 to 6 weeks. From a point of view of an NHS patient, it is longer, and it's more in the region of about 3 to 6 months. However, it's something that is varying at the moment, depending on the pressures of external pressures from the NHS.
Okay, did I miss anything else out on that one? BMI? No, I haven't. Right. On to the next one. Following an MRI, I've been diagnosed as having osteoarthritis with an extruded lateral meniscus and a detached fragment sitting at the back of the knee. I am currently awaiting an initial NHS appointment at the Horder Centre to discuss options. My physiotherapist has suggested arthroscopy may be appropriate, so I'd like to know more about this, and also the difference between an extruded meniscus tear in terms of treatment options and prognosis.
Okay, so generally, I mean, going back to if I go back to the appropriate image, if I can find it, which is this one. As you can imagine, as arthritis develops, the two surfaces come close together, and I mentioned about the meniscus being in the middle of those two surfaces. So the worse your arthritis, the closer it is together, then the less room there is for the meniscus to sit where it belongs, and therefore often gets squeezed out. And that's what an extruded meniscus is. It is essentially a sign that you have arthritis. It's a sign that the two surfaces are much closer than it should be. And as you can imagine, when the two surfaces are putting a lot of pressure on the meniscus, often it gets extruded, sometimes it gets torn or frayed. Going back to what the treatment options are, it very much depends on what the symptoms are. So regardless of what the MRI shows or the X-rays show, if I see an individual who has, we'll say, occasional sharp pains, as a main problem, or mechanical symptoms, the knee giving way is the major problem, then I would say that keyhole surgery definitely is something that can be that can improve their symptoms. If their main symptom is around pain, and not being able to control it, increasing pain with activity, waking up through the night, then arthroscopy really isn't going to do much for that. So it very much depends on the individual setting, not just the MRI or images.
Okay, thank you. There are quite a few questions here, actually. Somebody has asked something about general knee pain options. I suppose that's probably drug related.
General knee pain. I suppose that's fairly vague.
It is a bit. Sorry.
It depends. I would say is the ultimate answer to that. And it's the job of a surgeon like me to try and work out specifically what's causing that pain, and therefore how we take it away. The knee is an extremely complex joint, and a lot of different types of pain can be caused by different types of anatomy around the knee. And so I'd suggest that general pains need to be honed or zoned into a specific cause, and then it can be treated.
There are actually, there are quite a few questions looking at these, actually, people asking what type of pain they should take. How about diet as a factor? Can that impact how bad arthritis is?
I suppose this has been topical over the years. I don't think there's been an absolute large study that's definitely proven 100% it does. Anecdotally, and smaller studies have certainly proven that you'd say more inflammatory type foods can make your pain worse, and that's generally things with high trans fats, things with lots of sugar. They put the body into a pro-inflammatory state, which you can imagine may well affect all of your body and then make your arthritis worse. And conversely, a lot of things like a Mediterranean diet, so a lot of omega-3 fish oils, those sorts of things, that tends to be anti-inflammatory just in nature, in the way it works, and so often that can improve people's symptoms. One of the things that's really common that people say to me is they go abroad into a hot country and their pain gets better, and I do wonder if actually most of us who go to a hot country, our diet automatically changes. We don't crave the same sort of the things that we're going to be craving over Christmas, for instance, the roasts and the pies and things to warm our cockles by a fire when it's 32 degrees in Mallorca somewhere. We tend towards the fishes, we tend towards the salads, and that tends to be more anti-inflammatory in diet. So I do wonder if diet has a major role to play in that. So I think it's one of these things that you would say it certainly won't hurt, so we may as well try it.
So, well, I suppose it's all about marginal gain, isn't it?
Absolutely.
You can do something with your diet as well. And also, we have somebody here who's mentioned not much of an explanation, but cortisone injections as an alternative to surgery, and that's probably worth covering, although you have done to some extent, because I know it's limited how many you can have.
Yeah. So, I mean, ultimately, cortisone injections, visco supplement injections, they're a temporizing measure, and that if you're lucky, maybe out to a year. For most people, it's less than that. It's not necessarily a very good alternative to surgery because it doesn't give long-term relief. And the reason is what we spoke about before, which is, you still have that grinding away causing inflammation. The steroids in your knee reduces the inflammation but gets absorbed by the body. And so if you're somebody where the steroids get absorbed very quickly, and then it may not work at all or work for a week or two. If you're somebody where the steroid gets absorbed slowly, you may get 6 months, 3 months relief from it. And this is really where the new arthroscopy injection comes in, because it can't be digested by the body. It's absorbed into cells. It's completely inert. And as it stays there, it forms a scaffold for the body's own cells to grow into it. So a lot of people who have had very good relief from it for a number of years even having a knee replacement after that, 5 years down the line or more, or 6, 7 years down the line, there's no trace of this because it's all incorporated into the body. So really, I think there's less and less sort of indication for steroids and other visco supplements and arthrosamids, really, where I would be going with my injectable through management.
Right. Okay. Thank you. Oh gosh. Sorry, Tofi. You might need to help me on this one.
No worries.
Arthrosamid injections, and nothing else is written.
Yeah, no, that's exactly the injection I was talking about.
That's exactly it. Right.
So it's the arthrosamid is the hydrogel injection.
Okay. How do you say it?
Arthrosamid. Or
arthrosamid. Right. Excuse me, everyone, for getting that wrong. I think the others are. I'm just going down here. Visco supplementation injection. Somebody's asked a question.
Yeah, so that again falls into what we've just discussed. So I hope that's answered it.
Right. And I think that's it. Actually, going through the questions, I think there are others that are just really very much the same thing. How to deal with the pain. Whether there's anything that they can do with their diet, and then obviously
ultimately optimum pain relief is something that often people ask me about, and unfortunately it's a very individual thing, and it's all about trying to find the balance between whatever medication it is, trial and error, to try and find what actually helps the most. And when that's stops helping, and that's where we as surgeons come in with alternatives like the injectables or surgery.
Okay, I think that's it. Unless anyone's got any more questions that perhaps we haven't covered here in the list that we had, if you could type them into the Q&A now, and we can make an attempt to answer them. I don't see any more. Is there anything else that you would like to cover?
I think...
Oh, hang on. I've got another question has come through. Can I have a robotic knee replacement on the NHS?
That's been extremely topical here. I wish that was the case, but at this point in time, it isn't.
Hopefully in time that will change, and everybody will be having robotics. There won't be an operation without a robotic assisted surgery.
That time will come. I think that time will come. But not yet.
Lovely. All right. I think that's it. I don't think we have any more questions coming through now. I mean, that sort of leads me to say thank you very much, Mr. Oni, for providing your insights this evening, and to everybody who came along and has joined us. Tomorrow you will all receive an email with the copy of this video if you want to watch it from the beginning. I realise that some of you actually did turn up sort of up to 10 minutes late, so you will get a copy of it to see part of the presentation that you've missed. And if you want to contact us in any way, there will be details there as well. So I think that's it. Thank you very much. Have you got anything else you would like to add?
Not at all. Thank you very much. Be a pleasure to see you in the future if need be.
All right then. It was a pleasure then. Thank you very much.
Cheers. Bye now.
Bye.